Welcome everyone. Let me introduce myself. I'm Vanda, Máté, and I will be talking in a couple of minutes about the personalized pediatric oncological treatments for enhanced therapeutical effects and side effect optimization. I work at the first department of pediatrics as a senior resident. My supervisor is Miklós Garami, and my vision is to eradicate childhood cancer. And my mission is improving the therapeutic success for pediatric oncology patients with personalized approaches. So on this way to eradicate childhood cancer, my first step would be assessing the efficacy and toxicity profile of additional targeted therapies in pediatric oncology. And the second will be focusing on finding the best of all treatment for diffuse intrinsic pontine glioma. So about my first topic, why is this so important? Every year, 400,000 patients are diagnosed with childhood cancer. That means that every 3 minutes, one child is diagnosed with childhood cancer. So by the time I finish my presentation, 3 children will be diagnosed by cancer. In high-income countries, 80% of children can be cured, but in low-income countries, only 30% with our conventional therapies, such as radiotherapy, chemotherapy, and surgery. To improve this, we would like to use targeted therapies and see their effect and toxicity profile when used in combination with conventional methods. So our question is, does additional target-specific therapy change the outcome of disease compared to conventional oncological therapy alone in pediatric oncological patients? Our hypothesis is that additional target-specific treatment improves the survival, yet it doesn't have more side effects. Our goal would be to establish a target therapy-based protocol for these children. During our selection, we found 23,000 articles, and out of this, only around 200 were eligible. Our first outcome is the event-free survival, which you can see that at the 4-year and 5-year follow-up period, it was beneficial for the interventional group, so the targeted therapy group in both cases. If we go on to the overall survival, which is the hardest outcome of all, you can see that the hazard ratio for mortality was lower in the interventional group than in the conventional group alone. When we proceed to the most difficult to treat tumors, such as CNS tumors, you can see that the best survival probability is achieved when we use chemotherapy and targeted therapy together. So, what are the adverse event profiles in the 2 cases? During our assessment, we could see that the targeted and chemotherapy group were almost the same adverse event profile as the targeted therapy group. But we did not stop there. We further assessed 363 different types of adverse events according to the common terminology criteria of adverse events, which was then categorized into 20 different outcome types. The most frequent ones were gastrointestinal disorders, blood and lymphatic disorders. So, for example, vomiting, diarrhea. Vomiting was approximately the same in the targeted therapy group compared to the combinational group. And the only difference was in the diarrhea, which was significantly more prevalent in the chemotherapy group. If we go further, we can see that this thorough analysis lets us discover the different types of adverse events in different types of tumors, such as the CNS tumors. We said that the combination effect is better for the CNS tumors, and we can see that, for example, the anemia was almost the same in the targeted therapy group as the targeted and chemotherapy group. And we also assess these side effects according to their grade. So we could see that severe anemia, which is defined as grade 3 or more severe anemia, was also the same in both groups. So to sum up, our analysis is a comprehensive review that implements targeted therapies in hematological malignancies and solid tumors. Non-comparative studies were also included, and the control studies focused on hematological diseases, and solid tumors are underrepresented. Therefore, clinical trials should be done for CNS and non-CNS solid tumor patients as well. What is the implication for practice in this case? Targeted therapies can successfully be added to conventional therapies as they have similar toxicities as used alone, and we can see that they improve survival. So the conclusion is that targeted therapies can and should be added to as complementary therapy to improve survival in pediatric malignancies. The best survival probability can be attained using combined treatment, using conventional and targeted therapies together in pediatric CNS tumors. The combination of targeted and conventional therapies cause similar number of adverse events as targeted therapies alone, and RCT should be designed for patients with CNS and non-CNS solid tumors. If we further go on, you can see that we are at the article writing stage, and we plan to finish it this December. My second topic is comparing the effectiveness of different therapeutical approaches in the therapy of diffuse intrinsic pontine glioma. Why is this a very important disease? It's very common in childhood, and you can see that it's located in the brainstem that is responsible for our vital functions such as breathing, eating, sleeping, and so on. You can see that this is a normal brain, and this is the location where this tumor would grow. You can see the pathological picture on the side, which contains the tumor. So you can see that these vital functions will be compressed here, and this is why this is a very high mortality disease, because if we actually surgically want to go in this area, we might cause death for the patient. So this is why it is surgically non-approachable, and therefore, because there will be no surgical intervention, the blood-brain barrier will remain intact. No therapies for DIPG have been curative so far. The mortality is very high in this disease. It's 99% for 5 years, and the median overall survival is 10 months. The main symptoms of this disease, or the main symptom of DIPG is vomiting and also gait disturbances. And the problem is that once it's diagnosed, there's a very quick progression until death. So our question is there a difference between the different therapeutical types in DIPG? And if so, what is the best? Our populations is patients with DIPG. We are comparing all different kinds of modalities, and we would like to assess the response according to the RECIST criteria, the response evaluation for solid tumors, defined as complete remission, partial remission, stable disease, progressive disease, and death. We would also like to assess the quality of life and look at the adverse events according to the common terminology criteria for adverse events. Our hypothesis is that there is a therapy among the available ones in the treatment of DIPG that is superior in the effectiveness compared to the others. Our aim is to establish a protocol or a treatment guideline based on the most effective therapeutical modality to improve survival. Our second progress is at the stage of the Prospero registration. It has been finalized. And to sum up, I would like to draw attention to the fact that targeted therapies do improve survival, yet do not have a severe side effect profile compared to targeted therapies alone when we use it in combination. And in the treatment of DIPG, we would like to assess what is the most beneficial treatment for the patients. Thank you for your attention, and I would like to end with this quote. In fact, hope is best gained after defeat and failure, because then inner strength and toughness is produced. Thank you.
Among the patients, were there any studies in which there was surgical intervention?
Yes, basically all of the studies that we looked for were either the comparative studies, so in all cases, conventional therapy is used for the different types of cancer. For example, in case of CNS tumors, there is a surgical intervention in the beginning. Of course, for hematological diseases, there's no definition for surgery because there's no need for surgery. And for non-solid tumors outside of the CNS, surgery is also included. So we did not exclude articles consisting of surgery because it's a must for the treatment of these diseases.
And was it possible maybe to run a subgroup analysis with and without surgery in certain tumor types?
The surgical methods were also actually collected, so there is a possibility to do a subgroup analysis But we didn't mainly focus on that. Because there were only a small number of randomized controlled trials, first we included only the randomized controlled trials that were doing the comparison. And in the next phase, we looked at the phase 1 and 2 one-arm studies as well.
Maybe we have time, and maybe you can summarize a little bit that how can we target therapies. So just if you can summarize.
Thank you for your question. There are different types of cancer, as you could see that there's hematological, CNS and non-CNS tumors. For hematological tumors, they're quite homogeneous, and for them, surface markers are most commonly used for determining therapy, such as antibody therapy for CD19 and so on. For solid tumors, we can do immunohistochemistry and also find surface markers. In case of surface markers, we can then use monoclonal antibody therapies, and we can also look at different genetic alterations using next-generation sequencing, which means that if we find targetable alterations, we can, for example, use tyrosine kinase inhibitors to target them specifically intracellularly.
I just wonder about your second project. I mean, you just started, but probably you already kind of have access to the literature or a big part of that. So is this glioma is genetically homogeneous?
If you look at genetic profiles for CNS tumors, you can see that for each and every patient, the profile is different. There can be groups, for example, not in case of DIPG, but for example, for medulloblastoma, it has been quite well described that there are different pathways affected in the tumor progression. But for example, in DIPG, there's a stem cell problem as well. So for example, we had the idea that maybe a stemness inhibitor could be used in a clinical trial to improve the outcome of this disease. But I think the answer is also very hard for this question because DIPG is not very accessible for surgery. So actually having the tumor sample that we can make analysis of is very difficult. One possible option would be to use a liquid biopsy, which would be gained through the CSF, but because this is contained inside the brain, it's very highly likely that the tumor cells will not appear in the CSF. So we have further questions about how we can actually see the different genetic types of DIPG.
How about microRNAs? I mean, there are studies on microRNAs in the blood that may be different types or of glioma actually could have a different profile, and then you could get because what you ask is really, I mean, probably targeted therapy is going to be the way at the end. I mean, whether the target is a stem cell or some kind of pathways, I mean, that is still an open question.
Yeah, I think that the answer lies in the availability of the tumor samples. So I think that CSF would be the best option to gain this information for both the microRNA and for both the DNA sampling.